Thank you, Deepa. Okay, so I'm Vino. I've met a lot of you. So I'm going to talk to you about what new research has happened really in the last year, and some very exciting trial results. So we have this sort of, we've called ourselves the London Muscle Channel Research Group, and we really are sort of leaders nationally and internationally in research in channelopathy, and really, really grateful for all of your participation in all of our research. So the first thing I'm going to tell you about in a bit more detail is our clinical trial. So we have just published this recently in the last couple of weeks, and it was a major clinical trial that we ran through our hospital here, comparing mexiletine and lamotrigine in myotonia to see how they compare to each other. And as you've heard from Deepa, we've been using mexiletine for a long time, but now more recently, lamotrigine has been shown to be effective. So looking at how they compare to each other. And before I go into the results, really, a huge thank you to all of our patients that participated in the trial. We had 60 people enroll in the trial just from our centre here, which is just fantastic. And we really couldn't have done it without with all of your involvement. So thank you again. So the trial compares lamotrigine and mexiletine, and as you all know, when you start these medications, you start at a low dose and you increase up, and that's what we did in the trial. And you start on one of the medications, and then you have a break in between, and then you swap to the other medication. And that way, each person that was involved in the trial had both of the medications, and we recorded how things improved and their experience in the trial on both medication. And the reason we have a break in the middle is so that the medication that you've tried first is completely out of your system, and then we see what the effect of the other medication is. So that's the kind of design of the trial, and it's called a crossover trial design. And then the things that we looked at particularly are the scores, and a lot of you will be familiar with these scores because we do use them routinely in our clinics as well. And often Ivana, our research nurse, will send you this to do in our research packs as well. But the scores are the interactive voice response diary, or the IVR diary, which is really a score from 0 to 9, and that's a very useful score that we find to scale myotonia from 0 to 9. And then another score called the myotonia behaviour score, which is a scale from 0 to 5. And similarly, 0 is no stiffness, and 5 is the worst stiffness. But in the myotonia behaviour score, there's some sentences to each of the numbers, which can be a little bit help define a little bit which number you might choose there. And we also kept a sense of how much activity patients were doing during the trial, because we've spoken about how important and how related activity is to your symptoms. So now, the results, and this is really the first time we're presenting it it's only just been published a couple of weeks ago, so we're very excited really about this. So out of all of our patients who were on the trial, the average age was 41 out of the 60 patients, and most people started to have symptoms, around the age of 7. So people have really had symptoms for quite a long time in their lives, and that's why we know it's so important to have treatment for myotonia, because it affects you, during really the whole course of your life. And then the average scores for the two scores I've just spoken about, for the IVR score is 5.3. That was the average out of all the patients. So, quite significant symptoms that this group of patients had. And the mean myotonia behaviour score was 2.93 or 3. So the first score's out of 9, the next one's out of 6. So you can see we're sort of in that range of being quite symptomatic or affected by myotonia. And we always look at how well you've stuck to taking the medication, and the patients in the trial did stuck very well to the medications. And so this is just the graph that I'm going to show you just as a summary to explain the results. You can look at the paper online, which goes through lots of sort of medical technical details, but I think this graph really gives us a good idea of the comparison. So on this side, your left is mexiletine and this side is lamotrigine. And the bars represent how much there is improvement from before starting the medication, okay? So if we take the blue one, which is the IVR, which is that first score, the IVR score from 0 to 9, this on mexiletine, our patients had 27.8% or about 28% improvement from before they started mexiletine over the course of to the end of the trial, okay? And on lamotrigine, that was 27%, so, or 26.8, so about 27%. So what, and I'll talk through the other ones as well, but just on this score, which was the kind of the primary outcome or the main score we were looking at, the reduction that we saw in myotonia and symptoms was very similar, was, almost identical, 27.8 and 26.8 between mexiletine and lamotrigine. And so, really comparable effects of mexiletine and lamotrigine. And we saw that on all the other measures, so we looked at lots of other outcomes or other scores as well, the effects of mexiletine and lamotrigine, again, were very comparable, very similar. So the orange is the myotonia behaviour score, which is the 0 to 6 score, or 0 to 5 score, and there's 21% reduction from before you started medication and with mexiletine, and 20% reduction with lamotrigine. So again, very, very similar. We also looked at other things like pain, which is a big component of the condition for our patients, as I'm sure you'll attest to. And with mexiletine, there was a reduction of 31.8% or 32%. The pain is the yellow. There's a reduction of 12% or 11.73%, and with lamotrigine, 11.82%. And this is looking at the sort of average pain, the yellow bar. But we did look at some other types of pain, like the most severe pain and the times when you had least pain. And actually on the pain scores, lamotrigine did come out a little bit better than mexiletine. And actually that makes sense, because we often use in other types of neurology, in sort of beyond muscle diseases, sometimes lamotrigine can be used for types of pain syndromes, for types of facial pain and other types of pain. It can be used. So it makes sense that actually lamotrigine was a little bit better than mexiletine for managing pain in patients who have myotonia. We looked at the time to sit to stand, that's the grey bar, and some of you may have done this when you come to clinic, where we get you to sit and stand from a chair for 10 times and record how long that takes you, and that's a really good measure of your stiffness in your spine and your upper leg muscles, having to do that movement. And if you might warm up, or you might get worse as you do the movement. So when you do those 10 movements, it's quite a good measure that we use. And as you can see with the grey bars, again, mexiletine and lamotrigine were very similar, so 32% and 30%. Okay. And the last one, and I'm just going to point out, is the fatigue scale. So the FSS is a fatigue questionnaire that you may have come across if you come to our clinics, and that it gives us a sense of how much fatigue is affecting you from your condition. And with mexiletine, there was a 12.3% reduction, and with lamotrigine, there was a 12% reduction. So across all of the measures that we looked at, they were very much comparable. We looked at side effects, and so the most common side effects, as you may have experienced, is indigestion and reflux, particularly with mexiletine. But actually, we also saw some indigestion and reflux with lamotrigine. But as you can see, how many days was a lot less with lamotrigine. So 130 days all up across all the patients, and 208 days all up with mexiletine. So you can get some reflux actually with lamotrigine as well, but it seems to be half almost. So quite a bit less. Headaches and palpitations and some mood changes we also saw as the most common side effects. There were other rarer side effects because everyone's different and everyone experiences medications differently, of course, but these were the most common ones that we saw. And This is a bit complicated, but just to sort of summarize what it says, basically we test at the end because everyone's blinded during the trial. So you don't know what medication you're getting. And we were blinded as well. We don't know what medication our patients were taking during the trial so that, we're not influenced or biased or swayed in any way. And at the end, we get our patients who've done the trial to guess which one was which. Do they think they had lamotrigine first and then crossed over to mexiletine, or the other way around? And actually, basically, we weren't very good at guessing. People got it wrong either way, and some people got it right. So that again supports that actually lamotrigine and mexiletine are very comparable in how they're working, very similar. So based on our trial, we have come up with this treatment algorithm that's published in our paper as well. And this is not something that we need to 100% stick to, but it's a sort of guideline or something that we might think about when we're looking at treating your symptoms of myotonia. And we've thought about the results of the trial, but also side effects and other things that we might take into account. So, for example, if you have heart disease, we know that mexiletine can sometimes, those that are on mexiletine know that you have to have ECGs every year and you need to have that cardiac monitoring. So if you do have heart disease, for example, then lamotrigine would be a good option for you to go straight onto, okay? And similarly, if you have things that might put you at risk of heart disease, like high blood pressure or cholesterol, diabetes, then lamotrigine would be a good option for you as well. Deep has spoken about pregnancy, so lamotrigine has very good safety data in pregnancy. It's dose dependent, so low dose, is very safe in pregnancy, and it's been used a lot. It's been in the market for over 30 years for epilepsy and other conditions. We have a lot of data in pregnancy. So if you're a young woman and thinking about planning a family, then lamotrigine would be a good first choice for you. Obviously, if reflux is a big problem for you, then lamotrigine would be a good choice. And as I said, lamotrigine came out a little bit better with pain. So if pain, is a problem, then lamotrigine might be a bit better for you. And then otherwise, there's really a sort of choice about lamotrigine and mexiletine, and they have some differences in the way they act. So mexiletine kicks in quite quickly, but then it also comes off quite quickly. So if you skip a medication, for example, or skip a dose, for example, you might notice it really quickly. So, there are some personal preferences. Some people prefer to kind of take it as they need, whereas lamotrigine is much smoother in its action, but you also have to build up the dosage. So, there's some personal preferences, or perhaps you don't want to have an ECG every year on mexiletine, for example, and therefore you want lamotrigine. But for some people, they prefer to take a little bit extra mexiletine before exercise, and so you get that little bit of a boost, and so mexiletine might be better for you, whereas lamotrigine doesn't work so quickly, doesn't kick in straight away, so you can't really do that with lamotrigine. So there's then the sort of personalised treatment plan sort of comes in consideration, and that's what you would talk to us about and go through when you come to see us in the clinic. So this is a sort of guideline that we've recommended from the trial. So then very quickly, I'll just reaching time, but I will quickly whiz through our other research. And of course, if you want to talk to me about the trial, please do come and find me. But very much a huge thanks to all of our patients involved. So very quickly, Ivana, our research nurse, and Merva, our clinical fellow, are conducting a sort of recording ongoing data. And this is quite common in any kind of new medication. You sort of do what's called post-marketing research, but just to see how things, when our patients do start taking them, and keep an eye on things and keep a record of things. So they'll be collecting data in sort of our clinic as patients more and more start to use lamotrigine. So you may hear from Ivana and Merva, or you might already have been involved. And their data so far in the sort of outside of the trial in the real world it reflects what we found in the trial, that it is helping the lamotrigine. Now, the other project or research study that is coming up is one in muscle MRI. So we spoke about this at our last research, at our last patient day, but we have already done an MRI study looking at patients with periodic paralysis. because MRI is a really good way of looking at what's happening in the muscle and understanding if the muscle is damaged or affected. And it gives us that really fine understanding of the muscle, and also gives us something to compare to if we repeat the MRI, say, in several years' time. So it's a very useful way of assessing and managing things. And we've used the sort of standard muscle MRI techniques to do this, and that's what we looked at in our previous research study. Now, our next project, which you'll hear more about and to keep your eyes out for, is a study looking at new MRI techniques. So it's a particular MRI technique called MRI diffusion, which looks at, as it says, diffusion, so movement of water, movement of ions across the muscle. And it is a really exciting technique in MRI, and it's only really been looked at in a few other muscle conditions outside of periodic paralysis, but it looks really promising in those conditions. And because we're talking about ion channels and the muscle membrane, and it really holds promise for looking at things in more detail in periodic paralysis. And importantly, as I mentioned, as a good way of monitoring the condition underneath and seeing if it is helpful for monitoring. So keep an eye out for this. We are waiting still for all of our approvals to come through, and then Merva will be the one to contact if you're interested in being involved. And again, we'd be very grateful, but also it's a very exciting new technique to look at. Our cohort study is always running, and so this is like a research registry, really, and so you'll get often posted out a research pack that has a consent form. The consent form is broad, it covers everything, but we'll only really ask you to do the questionnaires, and if there's anything extra, we'd contact you and talk to you about that. So please do, if you do get that, and share it. There's a reply paid envelope with it, and do send it back to us with your questionnaires there. And I mentioned this last time, but the cohort data, that registry, has really helped us understand lots of things about your conditions. So for example, one of the things is that our understanding of pregnancy and the impact of your condition in pregnancy and vice versa has really come from that data that we've collected from you, giving us a sense that 70%, for example, of patients with myotonia do get worsening of muscle symptoms during pregnancy, and that's really come from that cohort. So it's really, really helpful when you're involved and engaged in that registry. Their other research projects are with Rupi Maniko, who is our lead scientist in the lab, and he's doing sort of more genetic lab-based research, particularly looking at patients who develop weakness early on in childhood, which are particular, specific, very rare variants that Rupi's looking at now as his current research project. And Sarah Holmes, our physio, is also very research active, and she's recently done some ATS focus groups to understand, what we should be taking forward, and to get a better understanding of what's important to you. So I'll leave it there. I think I'm already over time, but thank you all for your engagement and research. It's very exciting to be able to understand and develop treatments, and if you're interested, always reach out. Thank you.